Good evening, everybody, and welcome to the North American CF Conference Highlights webinar. We are super excited to be here to present to you guys today. And just a few housekeeping notes before we get things started off. So this event is being recorded and will be posted on YouTube. Everyone watching tonight will receive an email with the link to that recording. And to turn on the live Spanish translation, you can click on the interpretation button in the Zoom menu as seen on the screen. And at the bottom of certain slides, you will see references to the NACFC presentations where you can learn more about the topic presented. We will post a link where you can find all the NACFC recordings on our YouTube channel. We'll have time at the end to take your questions live, so please type your questions in the chat at any time in the Q&A box. We won't be able to answer your questions about individual diagnoses or treatment plans, and we encourage you to use the information you learned today to have conversations with your own care team. And if you use the event chat, please make sure to change it to all panelists and attendees so that everyone can see your comments, because the default is to panelists only. And closed captioning is available, and you can turn on these subtitles by clicking the CC icon at the bottom of your screen. So now that we got a little bit of housekeeping out of the way, good evening, everybody. My name is Chyann Hoyle. I'm very honored to be the moderator for tonight's presentation. So I am 25 years old, living in Augusta, Georgia. I actually work as a microbiologist at one of the local hospitals here. And I've been involved in the CF Foundation for as long as I can remember. I was diagnosed at the age of 2 and went to my first Great Strides walk at 5. And now I am very involved in the foundation with things like ResearchCon. That's been the most recent thing that I've been a part of. I was actually one of the co-chairs this year, where I got to work alongside one of our panelists. And I really enjoy doing all things CF and really enjoy advocating for myself and for other patients with cystic fibrosis. So our first presenter will discuss the results of recent CF studies concerning CF-related diabetes, reproductive health, and the effects of Trikafta in people with CF. And our second presenter will discuss the potential approval of the vanzacaftor triple, and he will also cover the future of CF research, including genetic therapies and the development of non-insulin treatments for CFRD. Then we will answer any questions from the audience. So first up, we have Cynthia. Our first presenter is Dr. Cynthia Brown, and Dr. Brown is a professor of clinical medicine at Indiana University and is the director of the adult CF program. In addition to pulmonary and critical care, she is also board certified in sleep medicine. So please give a warm welcome to Cindy.
Thank you, Chyann. I really appreciate the opportunity to be here. I have about 15 minutes to cover some very high-level highlights from recent clinical trials in cystic fibrosis that were presented at the North American meeting. But as Chyann had indicated, please feel free to go to the CF Foundation YouTube channel, because most of these talks and research will be available there if you want to get more in-depth information. So I'm going to start with some information from a few different clinical trials, including PROMISE, HERO2, MAYFLOWERS, and COST-CF here in the next few minutes. I'm going to start talking about PROMISE. Now, the primary results of the PROMISE study have been previously published. This is a large observational study of Trikafta in individuals who are 12 years of age and older with at least one F508 mutation. And the goal of the PROMISE study is to look at the effects of Trikafta across a broad array of body systems. And we've seen some of the early results on the results of PROMISE on lung function, respiratory symptoms. But this study that I want to highlight that was presented by Scott Sagal on behalf of his colleagues is specifically looking at inflammation in the PROMISE study. And we know that individuals living with cystic fibrosis do have increased systemic inflammation, and the inflammation can perpetuate ongoing decline in lung function. What I want to highlight is that at between 24 and 30 months of therapy, that individuals on Trikafta experience decreased inflammation, not just in the sputum, but which is shown here, but also in the blood. Now, I don't expect you to know what neutrophil elastase, IL-1 beta, or IL-8 are, but what I do want to highlight is that in each case, you see this decline in the inflammatory biomarker that is present within 1 month of starting Trikafta and continues to be present over the entirety of the follow-up. The PROMISE study is ongoing and will be continuing to collect data on these individuals out to 5 years of therapy with Trikafta. So we're going to continue to learn from our colleagues in the PROMISE study. The PROMISE investigators also had additional posters and presentations looking at other organ systems affected by Trikafta. And some of the things that were reported at the NACFC included that Trikafta did not change pancreatic function or lead to significant improvements in GI symptoms. This means that if you are on pancreatic enzymes and you're 12 years of age or over, you're going to continue to require pancreatic enzymes. It also treatment with Trikafta did not lead to an increase in liver function enzymes or liver fibrosis, even in those on liver disease. And finally, it did not lead to any significant improvements in bone density. So we're beginning to learn more and more about the additional organ effects of Trikafta outside the lungs. I personally was honored to present on behalf of my colleagues from the HERO-2 study. HERO-2 stands for the Home Reported Outcomes in Cystic Fibrosis Study. And this was another observational study that looked at individuals, again, that were 12 years of age and older who were on or were about to start Trikafta. And these individuals were followed for 12 months. This study used an app from Folia Health, and individuals would track their symptoms and their medication uses on a daily basis. In addition, we asked individuals at the time that they enrolled in the study whether they had previously stopped any additional therapies. We used the data that the individuals reported and linked it back to clinical data within the CF Foundation patient registry for outcomes including lung function and pulmonary exacerbation frequency. So one thing that was important that we found was that at study entry, 42% of individuals had stopped one or more of their chronic daily respiratory therapies. And interestingly, 7% of individuals had stopped 5 categories of respiratory therapies. And you can see that the types of treatments that were discontinued, and all in about 20% of individuals, included airway clearance, Dornase, which is pulmozyme, hypertonic saline, or any type of inhaled antibiotic, including inhaled tobramycin, Caistin, or colistin. So 1 in 5 individuals was stopping at least one of these therapies. And when we looked at the outcome, the specific outcome that we were interested in was whether stopping a therapy would lead to an increase in exacerbation or lung function decline. This is very complicated, but I just want to bring your attention to what's within this red box here. This is a result of an analysis called a regression analysis, and this was looking at the rate of pulmonary exacerbations. So what's important to see is that anything that is right around 1 means that those who discontinued versus those who continued stayed roughly the same without any increase in their pulmonary exacerbations during the 12-month of follow-up. We also looked at lung function decline between those who did not discontinue and those who did. Now, these lines represent the predicted change in lung function based, again, upon a regression analysis. And what you can see is these are essentially parallel lines. And this also indicates that whether you did or did not discontinue, you did not have a significant change in the trajectory of your lung function decline. I'm going to transition on to looking at the financial burden of care in CF. This is the COST CF survey. And COST CF survey stands for the Cystic Fibrosis Outcomes, I think social, I forget all the, social needs and trade-offs due to coverage and financial burden. This study was conducted by the CF Foundation during the spring of 2024 to understand how the cost of CF care affects daily living and access to healthcare services. Up to half of individuals living with CF delay or skip care to save money. And they looked at this relative to the federal poverty level. Now, I don't expect you to necessarily know what the federal poverty level is, but I will describe that to you here in a second. But what I want to show you are the different categories. If you look at people that were less than 100% of federal poverty level, between 300 to 500% of federal poverty level, or between 100 and 300%, about half of all of those individuals had to delay or skip care due to cost. So if you think about 500% of federal poverty level, just to level set, for a household of one, that's $75,000, and for a household of four, that's about $150,000. So for a family of four, about half of individuals were having to delay or skip care, even if they made up to $150,000 within this survey. And the most common reasons why an individual might delay or skip care included the cost of their copays, insurance denials, and the concern about missing work and lost financial income because of this. Now I'm going to jump to 3 areas of CF outside the lungs, specifically CF-related diabetes, sexual health and family planning, and mental health. The second plenary session in the NACFC this year was all about CF-related diabetes. And CF-related diabetes is a very unique type of diabetes. It's neither type 1 nor type 2. It lives somewhere in this middle zone. So a type 1 diabetic is your classic insulin-deficient diabetic, which usually presents in younger individuals and is related to an autoimmune destruction of the pancreas. A type 2 diabetic is classically older onset with a slow, subtle increase in blood glucose and is related more to insulin resistance. And CFRD lands somewhere in the middle, where you have both impaired insulin secretion, but also some degree of insulin resistance. And it can be variable related depending upon your nutritional status, your whatever infection might be going on, whether you're receiving steroids, with a lot of both hypo and hyperglycemia. So both high and low blood sugars can occur. We know that CFRD has significant impact on a variety of clinical outcomes, including leading to worsened nutrition, decrease in lung function, and increased pulmonary exacerbations, and it can contribute to an earlier mortality in those with cystic fibrosis. In addition, there are significant long-term complications, including retinal disease, eye disease, neuropathy, and kidney disease. And it also significantly impacts mental health. And in my clinical practice, I certainly know, and I see this all the time, that CFRD is often a tipping point. It's just the last straw because you all of a sudden, now you have to eat even more, get more calories in. You have changing insulin needs that can can even develop spontaneous hypoglycemia with the variability in insulin production. There's just not a lot of predictability for many individuals day to day. It can be very frustrating when you're already dealing with this chronic illness that requires you to take enzymes with every meal and multiple respiratory therapies per day. Excitingly, though, Dr. Dorgan will be highlighting some of the future research and potential ways that we might be able to treat CF-related diabetes better in the future. Thinking about pregnancies, wow, Trikafta really led to a baby boom. If you look at every year before Trikafta was approved, there were 300 pregnancies or less in women with cystic fibrosis. But every year since Trikafta was approved, we've seen over 600 babies born to women with CF every year. We are continuing to learn about how Trikafta is impacting pregnancies and the safety of Trikafta in pregnancy over time. When you look at the decade between 2010 and 2020, so definitely including a time prior to Trikafta, it's interesting that 40% of all pregnancies were unplanned pregnancies in women with cystic fibrosis. And again, going to my own clinical practice, many women would tell me, I didn't know I could become pregnant. However, if you look at unplanned versus planned pregnancies, what you see here is that there was no difference in the FEV1 from pre to post. So if you look at the planned and pregnancies, there was a decline after. And if you look at the unplanned, there was also a decline, but the rate of decline was somewhat similar. However, those who had unplanned pregnancies had an increase in their pulmonary exacerbation frequency in the post-pregnancy period. Because of the data like this, as well as the increased numbers of pregnancies, the CF Foundation funded the MAYFLOWERS study. MAYFLOWERS stands for the Maternal and Fetal Outcomes in the Era of Modulators study. This is another observational study of women who become pregnant with CF. You do not have to be on a CFTR modulator to be enrolled in the MAYFLOWERS study. And specifically, we're looking to understand better the impact of pregnancy on maternal and obstetric outcomes, as well as infant outcomes. And for those individuals who are taking modulators, looking at how pregnancy influences the levels of modulators, and also including breast milk. And we also have a sub-study looking at glucose control in individuals who are pregnant, who have diabetes and are pregnant. Dr. Jane presented some of the interim data. So you can see that there are 279 mothers who have enrolled, but because the study is ongoing, there are only so far 239 babies that have been born. The average age of the women who became pregnant was about 30, with a pre-pregnancy FEV1% predicted of 83. However, it was a broad range of lung function, with the lowest FEV1 at 25% of predicted and the highest 123%. About 40% of women who were pregnant had diabetes. So far, amongst the pregnancies, we've had 95% have resulted in live birth, with 5% pregnancy loss. 40% of the infants that were born by a C-section with an average weight of 3.2 kilograms, which is just over 7 pounds. Most babies the average gestational age of the infants born was 38 weeks. Full term is considered 40 weeks. Preterm birth at 37 weeks or earlier occurred in about 1 in 5 pregnancies, and thus resulted in about a 20% extended NICU stay and having some degree of respiratory disorder. And so with that, I'm going to transition next to talking about the state of the literature in mental health for individuals who are on Trikafta. C.J. Bathgate presented this slide regarding mental health and the lay of the land for individuals on modulators. What I want to bring your attention to is this is a series of studies that were published between 2020 and 2024. And the N is the number of individuals that were included in these case series. So some of these were as few as just one individual. And the greatest number was Dr. Spolatini's paper that had 19 individuals included. So the bigger picture is we still have a lot to learn about mental health in individuals on Trikafta. But some of the different symptoms that were reported have been mood disorders like depression and anxiety, significant sleep problems, and sort of this mental fogginess and memory issues among the others that are noted there. The Module CF study looked at 197 toddlers between the ages of 2 and 5 and looked at their mood and neurocognitive changes within 1 month of starting a modulator. And you can see that about half of parents reported behavioral changes within 1 month, the greatest of which was sleep changes, but there were about a third also had some attention disorders. And within this group, 85% had no previously documented issues, behavioral or sleep issues. Another group that's looking at this is the Your ETI study or YETI study. In this group, individuals were asked to report their changes in perceptions of their health. This would be either reported by adolescents or caregivers. And these were all individuals on Trikafta. So this is a little bit of a complex slide, but this specifically is looking at the change in how often you or your child was bothered by specific symptoms after starting Trikafta. So on this panel, it's sleep difficulties. In the middle panel, it's fatigue or lack of energy. On the far panel, it's brain fog or forgetfulness. So there is a group of individuals in the dark blue bars who got better, a group of individuals who stayed the same, and a group of individuals who worsened. And if you look at each one of these categories, the 7 to 13-year-old group were caregivers. And then for the 13 to 17-year-olds, there was a group that was patient reported, and there was a group that was caregiver reported. So the finding from this shows that by and large, most people reported no change in these symptoms after starting Trikafta. However, there was a percentage of individuals that were worsened, and the patients, the adolescent patients, were more likely to report a worsening than their parents. This group also reported similarly on anxiety and depression, with sort of a similar finding being seen, that the patients were noting these changes to be worse, while their parents and caregivers had not reported that. So this is very early preliminary data from the YETI study, but there is a lot to be learned from this group. So with that, I'm going to stop sharing my slides, and I'm going to hand off to Dr. Dorgan so he can tell us where we're going.
Thank you so much, Cindy. That was a great summary. Our second presenter is Dr. Dan Dorgan. Dr. Dorgan is an associate professor of clinical medicine at the University of Pennsylvania. He has been involved in the care of adults with CF since 2008. He has directed the University of Pennsylvania's involvement in many research studies for treatments in CF, including studies using inhaled gene therapy or inhaled mRNA for CF, and studies related to treating infections in CF. Take it away, Dr. Dan.
Thanks, Chyann. Yeah, so Cindy gave us a great overview of where things stand right now. And so we figured it was great to break this talk into what's the present state of CF and then where we're going into the future. So one thing that was presented, oh, actually, no, before I get to that slide. So in terms of getting back to where we stand, tying into some of the things Cindy was talking about, is we've really seen a lot of progress in CF over the past 20 years. So comparing 2003 to 2023, there are almost 2.5 times as many adults with cystic fibrosis now as there were 20 years ago. Cindy showed the pregnancy changes in the decade leading up to 2020 versus 2020 and beyond when Trikafta became available. But if you go back even further to 2003, the pregnancy numbers were even lower back then. So we can see that women with CF were having improving health already, and the pregnancy rate had already been going up even before Trikafta, before we saw the Trikafta baby boom. So now we're seeing 4 times as many pregnancies as we saw 20 years ago. Mortality has been decreasing, which tying into increasing life expectancy with cystic fibrosis. Lung function is getting better. This picture on the bottom left is showing just a snapshot of 7-year-olds in 2003 versus 7-year-olds in 2023 with cystic fibrosis, and just showing how lung function improved from average 80% of predicted to 94% of predicted. And then the need for inhaled antibiotics, again, tying into some of the things that Dr. Brown was talking about, that fewer children are needing inhaled antibiotics, fewer adults are needing inhaled antibiotics. So globally, a lot of people are seeing a lot of improvement with Trikafta. And now there's further research that's looking into new modulators. So the Vanza triple is the next one that had data presented at the NACFC conference. And so the Vanza triple is this combination of vanzacaftor, tezacaftor, and dut-ivacaftor And this was compared to Trikafta, elexacaftor, tezacaftor, and ivacaftor. Dr. Keating from Columbia University presented this data. Now, one difference with the Vanza triple versus Trikafta is the dosing for this is once a day rather than twice a day, just because all the components have a long enough duration in the body that once a day dosing is adequate. And so with this was really a head-to-head comparison on people who were already taking Trikafta. And so they had a starting period going into the study on Trikafta, and then they were randomized. So half of them were continued on Trikafta, and half of them were on the Vanza triple. And everybody was blinded, so they didn't know which one they were on. So somebody on the Vanza triple was getting a placebo in the evening because then they would know they would still be taking something twice a day, just not knowing which one they were on. And so this comparison here is just showing that dashed line over 0 is just saying 0 means there's no difference between one or the other. And then if there's movement in one direction or the other, so if this dot and bar were further over to the right, that would say the Vanza triple was clearly better than Trikafta. And if it was far over to the left, it would say that the Vanza triple was clearly worse. And so you can see with the data here, these numbers here are looking at lung function, and essentially the lung function was the same between the two groups. And then other things that they looked at was CF exacerbations. There was a very small number of CF exacerbations for either modulator, and the numbers were similar between the two. And then the other thing they looked at was sweat chloride, because the CFTR modulators actually can impact sweat chloride as potentially a sign of how effective they could be in the longer term. So a study like this is going only for so long. So when you're comparing exacerbations, it's hard to know, are you seeing similar numbers just because of the shorter duration? And would there be a difference if you went for a longer time? And there actually was slightly better sweat chloride on the Vanza triple than on Trikafta. So not something that's clear cut saying this is going to be clinically better than Trikafta, but potentially there might be a slight improvement. And so the FDA is reviewing the Vanza triple data with the expectation that they're going to make a decision on whether or not this is FDA approved by January 2nd. And so this could be something that's coming down the road as a potentially available medication. And this really it warrants discussions with your own clinical team about, is this a medication that's appropriate for you? There are plenty of people who feel perfectly fine on Trikafta as they are and might say, I don't want to change things. There are other people who may have one reason or another that they want to try the Vanza triple. One thing that's really important to be aware of with this study, though, is this was a study that was involving people who were using Trikafta and were not having problems with it. So there are definitely people, as Dr. Brown was highlighting, that have mental health side effects of Trikafta. There are some people who have liver tests that go abnormal on Trikafta and have a modified dose because of those side effects. So those people were not included in this study. So it's not we don't have a clear evidence of what impact there will be from switching from Trikafta to the Vanza triple. So and that's not to say that it's something people should not do. It's more just that it's something that people will need to explore sort of in real time with their clinical teams to see what impact is this having. It's not a guarantee that side effects on Trikafta will not happen on Vanza, but hopefully some people who cannot tolerate Trikafta potentially could have a better tolerance of the Vanza triple. But so that's where we stand now with treatments that are out and are coming out very soon. But then there's the big question is the roughly 10% of people with cystic fibrosis who can't take modulators. In some cases, that's because of side effects. And in some cases, it's because of the mutations causing that person's CF. So this was a schematic that was presented at the first plenary that was talking about genetic-based therapies at the conference. And so the lighter blue figures are the number of people who are eligible for a CFTR modulator therapy and tolerating it. And then the dark blue down in the lower right corner is people who have mutations that are not eligible for modulators. And there are certain mutations that we don't think there could be a better modulator that actually would help. There just are some mutations that don't seem that they would respond to any modulator. And actually, one thing I didn't mention on the prior slide is there are other modulators that are still being studied to see, Cyann Therapeutics being one company that's studying modulators to see if there's any further improvement that can be made with modulators compared to the ones that are available now. But there are some people who just will not have mutations that will not respond to modulators, no matter how good the modulator is. And then there's this group that's more of a purple color, that's those who just are unable to tolerate or are on a modulator but are just seeing a limited benefit from it. And so we're trying to find what treatments can help those who are not getting the full benefit from the treatments that are out now. So the CF Foundation has a huge drug development pipeline, obviously something far too big for me to go into in the 15 minutes I have to talk. And I'm going to be focusing on some of these things. But one thing to be aware of, which I'm sure will be put in the chat, is links to look at the pipeline. So you can really explore in depth if there are things that pique your curiosity that you want to look more into different specific areas of research within cystic fibrosis. But with this idea of genetic-based therapies, the whole idea here is if there's a mutated gene, can we bypass that mutated gene to create normal CFTR? Because in cystic fibrosis, it's non-functioning CFTR or decreased CFTR that is leading to the illness. And so in replacing this, at the first plenary talk, there was this great analogy that was drawn with the idea of we're trying to build a car. So you have the first step of the car is just the design of it. So somewhere in corporate headquarters, somebody is building a blueprint for this car. And so that's the equivalent of DNA. You have some central blueprint that's saying this is how this car is going to be designed. So in the case of CFTR, that's the DNA that's inside the nucleus within the cell. And then the next step is to create messenger RNA. And so this is essentially saying, well, we have our core blueprint that's in central headquarters, but now we need to take the instructions to the factory so the car can actually be built. Now you want to leave that central copy in central headquarters so that you have that for reference. So instead of bringing that copy out to the factory, you make a copy of it that's brought to the factory. And so that's what messenger RNA is doing. It's just a copy of the instructions that's brought to the factory. So in this case, brought outside of the nucleus into the cell, where the cell can then use it to make protein. And so then the next step is in the cell that protein is made. So in this case, the protein is what we call CFTR protein, which is supposed to then sit in the lining of cells, and it moves ions from inside of the cell to outside of the cell. The most common ion that it's moving is chlorine, but it has other functions as well. And so when we're looking at cystic fibrosis, now there's some change that's happened, so the car doesn't function. And this gets back into, it depends on what the mutation is. So if you had something, if we're using the car analogy, if it's some connection in the engine that just is loose and does not connect correctly, then maybe you have a modulator that's something that's just enough of a clip to stabilize that loose connection so that the engine can work and the car can run. But if you have something that is a much more drastic mutation that can't be just stabilized with a simple fix, or even a mutation that just is so early in the process that the car can't really be made at all, then modulators aren't going to help. So that's where we back away from the right side of the slide, because the right side of the slide is where modulators can help. It's where you have a protein that's made, but it's just not quite right. It's close, but it's not all the way there. And then maybe a modulator can stabilize that protein and get it to function. But if you have a mutation where you can't even get that sort of close to normal protein, now we have to back up to the DNA and the messenger RNA steps. And so this is where there are multiple different groups that are looking at different types of treatments, either at the DNA level or the messenger RNA level. So messenger RNA, again, those are the instructions that are sort of helping the cell or instructing the cell how to make the protein. And so there are companies that are working on delivery of messenger RNA into the cell with those instructions to make the protein. Now, one thing is messenger RNA, it breaks down pretty quickly. So this is something that we would not expect to be a permanent fix with messenger RNA. It would be something that people would have to redose. And part of these studies are looking at how often that would have to be redosed. Whereas there's also the question of, could you replace DNA and give somebody the normal functioning DNA for the CFTR gene, and can you deliver that into the cell? And part of this is, it's not just, can you create the normal messenger RNA and can you create the normal DNA? That's easy to do in a lab. The hard part is, how do you get it inside a cell and have it create its function? And so it's really that delivery to the cells that can be a challenge. And now messenger RNA has to get inside the cell, and DNA has to get not just inside the cell, but all the way into the nucleus, because that's where DNA is copied into more messenger RNA. But DNA theoretically could be a longer lasting solution. And depending on which type of cells, there are some cells that even function like stem cells in the lung and then can reproduce themselves. So there may be some versions of genetic-based therapies that if they could incorporate DNA into something that's at a stem cell layer, it might be a very long-lasting response that we see. Now, we're still very early in the research for this in people. So how this actually shows up over the coming years is something we all still have to figure out together as a community. But it's sort of the exciting directions that we're moving, that there are multiple different things that are being explored to figure out how can we come up with solutions that help everybody. Because with this, if you're giving somebody a normal copy of CFTR, it doesn't matter what gene mutation they have, because we're just giving back the normal version and we're sort of bypassing the abnormal version. So that's the idea of giving somebody an entire version of the messenger RNA or the DNA. And then another thing that was discussed was the idea of gene repair and insertion. So people have heard a lot about CRISPR and other gene editing techniques that have been generating a lot of excitement in the last decade. And so one idea is that one thing that could potentially be done is to insert a normal version of a big portion of the gene as a way of bypassing mutations. So in this example, they're showing the mutated CFTR gene. And so a gene is broken up into exons, or just different sections of the genetic material. And so there are 27 different sections of that, or 27 exons in the CFTR gene and protein. And so the idea here is you could have mutations. Those red bars are just the many different possible mutations. No one person has all those mutations, but just across many people, there can be those many different mutations. And so the idea here is now if we insert a normal version of exon 2 to 27, then it doesn't matter what mutation you have further downstream of that, because now what we're going to see is we put that inside the gene. So now the cell is going to read that gene through, and it gets to the entire normal version up through section 27, and it hits the stop signal, and it stops and sends out the messenger RNA to turn into protein. And it doesn't even matter that further downstream there are those mutations. We're not even getting to the mutations, so the mutations just end up being ignored. So again, this is the kind of thing that we're making progress with, the ability to do this in labs. And the question is, how do we get this to work in people? So it's things that are not in the immediate future. There's a lot of work to be done to get these things to a point where they could benefit people. But one thing that excites me about this is that not only is there just amazing scientific advances happening, but there are many different things that people are trying between messenger RNA therapies, DNA therapies, gene repair, gene insertion. So even if one of them doesn't work at all, the fact that many different things are being tried really improves the chances of having something work. Now, a big question that comes up for people is safety. When we're talking about DNA, RNA, people are worried about, what does that mean for it? We're talking about impacting genetic code, and people worry about, what's the impact? A question that often comes up is, what's the impact in terms of if I'm going to have children? Does that impact DNA that I'm passing on? And so, while those questions are not something that I have time to answer in detail here, I think the key factor to know is that there are so many different people who are looking at the safety of these therapies. So the study sponsor that's actually producing a new therapy, government organizations such as the Food and Drug Administration or the European Medicines Association or Administration, looking at its safety from a governmental level. The Cystic Fibrosis Foundation has the Therapeutics Development Network that does a scientific review. There's data safety monitoring boards whose whole job is to look at the safety of a treatment and to intervene if there's any concern about safety, to shut down a research project if there's concerns about the safety. Institutional review boards are doing that at the university level. So if a study's happening at 10 different universities, there are generally 10 different institutional review boards that are looking at the study. And the site study teams are looking at it. So if there's a protocol, a study team is going to say, hey, let me take a look at this study myself to make sure that I'm comfortable with this. And of course, any participant is going through a very long informed consent process to really make sure that they know as much as they can about the study and can decide, do I feel comfortable being in this study myself? So here's some examples of studies. Again, I'm not going to go into these in detail right now. These are great to explore on the CF Foundation's website in their clinical trials pathway. But I think the key thing to be aware of is getting back to this idea, there's a limited pool of people who are eligible for these studies at this point, because really what we're looking for is people who are not eligible for the modulators or are not getting a strong benefit from them. And so that narrows down the number of people who can be in these studies. So it's very important for us to come up with structures to work together to help give people access to be in these studies. And also, if you have interest in studies, volunteering and talking to your team about how do I get into these studies. And some of the slides at the end will talk about different mechanisms to do that. And one other way to be in a research study that does not necessarily mean being on a medication is there's the REACH study that the Cystic Fibrosis Foundation has coordinated, which is an observational study with the idea that anytime we're trying a new treatment, we want to compare it to people who are not on that treatment. And so the REACH study is a way to allow people to enroll in a study where data is being collected very rigorously and systematically as we would do in a research study to kind of create a big comparison group that hopefully will help us get more useful information out of the studies we do that actually do involve new treatments, because then we have that big comparison group to compare the new treatments to see if they're having the benefit that we want them to have. So the website for this study is on the bottom of this slide. And basically what happens is de-identified information, meaning your personal information is removed from it, so people can't tell who you are in the study, is put into the database. And it includes health information like lung function testing, blood work, other specimens, and then that data is used to help plan development of new treatments. So that's sort of the big picture of where things stand with genetic-based therapies. Granted, that's a talk that could go on for hours in and of itself to really get into the details, but I also want to talk about some of the other exciting research that was brought up in the conference as well. So looking at just other aspects of health and CF and some of the research that's going on. One big area that, again, getting back to plenary 2 that Dr. Brown referenced was exploring new treatments for CF-related diabetes. So it's a very difficult condition to manage because of a lot of fluctuations in terms of insulin needs. And so one thing that's been developed is this bionic pancreas. So the islet is the brand name of it. And there's a study that's being started called the Bionic CF study. Actually, at the conference, they announced that the first person had just enrolled in this study. And so this is for people who have cystic fibrosis-related diabetes. And basically, this is an all-in-one. I think a lot of people have heard about continuous glucose monitors and maybe using continuous glucose monitors, something that is ongoing on an ongoing basis, monitoring what your blood sugar is instead of you having to prick your finger and measure blood glucose yourself repeatedly. And then there are also insulin pumps that give constant infusions of insulin to try to maintain appropriate blood glucose levels. So the idea of a bionic pancreas is connect those two together. So the machine is those two components are talking to each other. So the continuous glucose monitor is talking to the insulin pump to help guide how much insulin should be given. And then the continuous glucose monitor is monitoring what's the blood glucose response to that. So the idea is, if this is something that works well, it could make managing diabetes so much easier in cystic fibrosis, because it could be a good use of technology to really simplify a lot of that, cognitive, just the mental energy people have to put into managing their diabetes, because a machine could potentially do a lot of that work for them. And then there are other studies that are looking at different treatments that don't use insulin for CF, because historically we've really only had insulin as our only option for treatment of CF-related diabetes. So there's semaglutide, which goes by the brand names Wegovy and Ozempic, which I'm sure everybody's heard about in the news because they've been quite effective weight loss drugs outside of the world of CF. And in some ways with modulators, there have been a lot of people who have gained weight and to some degrees in a healthy way, and to some degrees more weight than people want. So that weight loss effect may not be problematic for people who have gained more weight than they are looking to gain on Trikafta and have CF-related diabetes. There's empagliflozin, goes by the brand name Jardiance, which causes people to urinate out more glucose. This studying low glycemic index diets, so low carbohydrate, low sugar diets, trying to see. So basically, multiple different studies are looking at different aspects of potential treatments for CF to see if there are other things we can do to improve CF-related diabetes care. And then there are observational studies that are going on. So there's the Spectrum study that's studying the presence of CFRD or CF-related diabetes complications with thoughtful recruitment of multi-ethnic minoritized groups. So this is a study of people 12 years and older who have cystic fibrosis-related diabetes, just to look at the real-world impacts of it on their care. And then there's the Strong CF study that's trying to redefine nutrition, because often, weight is a very crude number, or BMI, that uses weight compared to height. And the problem with that is you could have people who weigh the same amount, and one person there's a higher proportion of that's muscle and bone, and another person there's a higher proportion that's fat. And so the idea is that we want lean, healthy tissue for people to thrive. And so the idea is that the Strong CF study is looking at different strategies for trying to optimize not just gaining weight, but gaining healthy weight so that people can really thrive. And then other studies that are looking not specifically at diabetes, but at other elements of just life with cystic fibrosis. So there's the PRIDE CF study that's exploring the interplay between having CF and identifying as LGBTQIA+. There's the HOPE CF study that's looking at the idea that, as we're seeing more and more people with CF, women and men, becoming parents, that now there's the challenge of how do I manage cystic fibrosis for myself while I'm also trying to take care of an infant, a toddler, and how that impacts the ability that people have to fit into their days to meet their own needs. So this health outcomes of parents with CF study is exploring that. And then there's another question that we're very early in figuring this out, and doesn't have as much in the way of formal research studies right now, but it's a big thing that's on a lot of people's minds. So to some degree, the one way that this is being explored in a research study is the MAYFLOWERS study. So the idea that if somebody's taking a CFTR modulator in pregnancy, what is the impact on their future baby? And so we have three different care situations here. You can have a mom who has CF and the baby who has CF. You can have the mom who has CF and the baby doesn't have CF but is a carrier, because any baby to a mom with CF is going to have at least one copy of the mutated CF gene from the mom. And then there's the real question that has come up that we really don't know the answers to yet, and people are very interested in figuring this out, is what if a mom who does not have CF becomes pregnant and then finds out that they're carrying a baby who's going to have CF? And what is the impact of taking Trikafta or other newer modulators during pregnancy? And is that something that will have a benefit? Are there potential harms? So these are big questions that people are trying to figure out. There's a upcoming CF Foundation sponsored workshop that's really exploring this a lot with Dr. Jennifer Taylor-Kausar and Dr. Sylvia St. who are chairing that session. So really these are areas of interesting, exciting questions that we have a lot of hope that this could really help people have thriving children, including newborn babies with CF. But we're still in the very early stages of learning more about this. And so as we're moving forward with research, there's this regional cooperative initiative. When we're working with a smaller and smaller group of people who are eligible for these studies of genetic therapies, or if we're just looking for new symptomatic therapies particularly for modulator ineligible people or modulator intolerant people who then have significant symptoms and need other treatments that could improve their quality of life. And just this idea of trying to provide access to clinical research trials for all people, because there's a large population of people who have historically just not been treated to the same standards medically by the medical field throughout the history of our country. And so how do we provide access, and not just to excellent clinical care, but also to research that can advance and improve clinical care in the future, particularly if you live in an area where my center is not participating. If you're at a center that you say, hey, my center is not a participating center in this study, how can I be involved in a study? Because I want to contribute to moving the care forward so that for myself and for others, the care can improve. And so this is where the Regional Cooperatives Initiative that the CF Foundation has put together plays a big role, is that CF centers across these different regions that are shaded on the map here. And of course, some of these, if you live near one of the borders for that, then it's not that you're limited to just the region that you're shaded in for. It's just this was a structure that the CF Foundation built to try to bring centers closer together so that people are talking to each other and talking about what studies are going on and what access they can provide. So if somebody's at a center where they're saying, hey, I'm really interested in this study, but my site is not a site for the study, that they can then refer to other sites more easily so that people can participate in research and help us advance care. And so I guess I should have pulled up those bullet points a moment earlier. But yeah, so basically we're trying to build research knowledge, improve access to clinical trials, and increase referral opportunities. And so if you also want to become more involved, definitely talk about it with your care providers in your own CF center. But also at a national level, Katie Howe has the role of clinical trial navigator within the Cystic Fibrosis Foundation. So she can help explain the clinical trial process, answer questions about participation in studies, provide personalized reports of studies that are enrolling. So if you give information about here's who I am, here's how old I am, here are the mutations I have, then she can provide information about, oh, this, you might be eligible for this trial or for that trial. And then she can help connect you with a site that is participating in those trials. So you can email trialnavigator@cff.org or fill out an online form on the CFF website to get more information. And then this slide is the end of my talk. I'll let Chyann come back on camera and she'll tell us more about CF circles.
Thank you so much, Dan. That was another great summary. So the CF Foundation has started a new program called CF Circles. Adults with CF are invited to join small group discussions that offer the opportunity to share stories and get support from others who have similar experiences. The first session is for people who are managing a prediabetes or a CFRD diagnosis, and the second session is for those who are diagnosed with cystic fibrosis as a teen or an adult. Topics for this session may include planning for an unexpected future, changing identities, and adapting your life after your CF diagnosis. And we really hope that you guys can be a part of that. So I will go ahead and remind you guys to submit your questions in the Q&A box down below, and I'll invite Cindy back up to the screen. Yeah, so thank you guys so much for joining us. We're going to go ahead and start the Q&A portion now. So first off, we had a question probably for Dan. Are the people who will qualify for the vanzacaftor the same as those already eligible for Trikafta?
Mostly. They did in the study identify a few more mutations that will be eligible for the vanzacaftor now. And these lists there are more than 1,000 mutations of CFTR. And so these lists of who's eligible become very long. So it's not possible to cover all the mutations, but there were some additional mutations that were identified as ones that could respond to the vanzacaftor. So that's also worth talking about with your team to see, is my mutation now added to the list?
Awesome. So what are the causes of CFRD, and are there any upcoming or current studies that are looking into this?
So it's interesting that there's a lot of research that has gone on, and I think the second plenary really described a lot about what we know about CF-related diabetes. My naive understanding before that presentation was that CF-related diabetes was almost like the type 1 diabetic, meaning that the cells that make insulin in the pancreas die off. And that's actually, you know, what some of the data that was shown in the plenary showed that wasn't actually the case, that those cells are still present there, but there's some impairment in how the insulin is secreted, and even resistance to the insulin in tissues. So we can't predict who's going to go on to develop CF-related diabetes at this point in time. We know that as you get older, more people have it. You know, in early childhood, it's less than 5%. By age 20, it's about 20%. By age 40, it's about 40%. But there's still a lot of ongoing mechanistic research to understand all the different pathophysiology that's going on in CF-related diabetes.
Well, thank you for that. So moving on to our next question, is there any data on the impact of Trikafta on sinus headaches or sinus problems?
So that is one of the outcomes that the PROMISE study is looking at. But there are a number of case reports and case series across different CF centers that show that sinus disease has improved. So symptoms, so there's a questionnaire called the SNOT, I think it's 22, but it's called the SNOT questionnaire. So that's like a standard sinus questionnaire, and it shows that people report fewer sinus symptoms after starting Trikafta. In addition, they showed some MRIs or CT scans of these individuals showing a decrease in the amount of sinus inflammation. So Trikafta can improve sinus disease.
Awesome, thank you for that. So, regarding genetic therapy, are there any plans to deliver the mRNA to places outside of the lungs? For example, ways to get it into the liver or the sinuses?
Yeah, so long term, that is the goal. Right now, the starting point has been with the lungs, partly because that's the area that's most severely affected in cystic fibrosis, and partly because it's a matter of trying to figure out, are we doing this right? Are we getting this treatment safely into people in a way that's having a benefit and not causing harm? And so then I think long term there will be explorations of, can we have this have a benefit throughout the entire body? So it's one of those things where I know it's hard for people to look at a time frame that looks far down the road, but I think it's just, when we're trying to do things safely, it's a matter of taking that one step at a time and trying to move as quickly as we can, but also in a way that's going to be safe. So, but eventually there should be treatment. The aim is to have treatments that affect all parts of the body.
Great. Well, speaking of taking it one step at a time, I do want to applaud you on that. So, given the current pace of development in genetic technology, looking into the future, how many decades away do you think that we are from a genetic cure for CF? And that can be either one of you.
Yeah, I think it's one of those things it's really guesswork. Because I can imagine it being within the next decade. But it's also sometimes when we're exploring new treatments, we run into, hurdles that we just didn't imagine. So my hope is that this is something that's coming within this coming decade. But there may be the possibility we find out, oh, this is harder than we thought it was going to be, and it's for more decades down the road.
I gotcha. I know it's a lot of guesswork. So, with our next question, I know Trikafta, some people are intolerable to the medication. That's actually the category that I fall into. So does the Vanza triple affect LFTs, or does it have any other symptoms like having upset stomachs or other GI problems?
Right. So in the study, it did not show that happening more than with Trikafta. But again, the people who were in the study were people who were tolerating Trikafta. So I think that's going to be an important conversation for people to have with their clinical teams to decide, how do I go about starting this? Since I had intolerance to Trikafta, does that impact, if I'm going to try Vanza, does that impact the way we try it, or do we just start at full dose and monitor? Do we start at more slowly ramping up? I think that's something that's really going to be an individual discussion with teams to figure out, what is the approach for each person to take at an individual level.
I gotcha. Well, thank you guys both so much. We have time for one more question, and I would actually love to hear both of your thoughts on this. So, what research or developments in care are you most excited for over the next year?
So I think from my standpoint, because of my own research that we've been looking at in treatment simplification, the UK has a randomized trial that's looking at 1-year outcomes when people are randomized to stop hypertonic saline or Dornase. I think that will add to our growing body of literature around treatment simplification. And then the other thing I'm really interested in, I'm an adult pulmonologist, but thinking about the further research and understanding about what it's like to age with cystic fibrosis. So are we going to see new complications, new concerns around cardiac disease or other complications that we're going to need to be more aware of?
And I think my answer touches on some of the things I talked about in my section. The Bionic CF study I'm really excited about from a practical standpoint. Is this a way that in the near future we can make a real difference in the quality of life for people who are dealing with one of the most challenging aspects of having cystic fibrosis? So I'm hoping that shows a way to make CF-related diabetes care a lot more manageable. And then when it comes to the genetic-based therapies, it's really just that idea that there's so many different things that we're trying. I don't know which ones are going to work and which ones aren't. But the fact that we're trying many different things means that even if some don't work at all, that it gives us more and more chances to have something be successful. And that excites me.